Dan, are you able to hear me?
Yeah, I can hear you guys.
Perfect. I can see people are trickling in. We have about 50 attendees so far. Um, it is 4 o'clock, Dan, so I think what we can do is kick this off. I just wanted to begin by saying if anyone is having any difficulties with the webinar, audio, video, visual, please use the chat box to communicate. We have a few people moderating here. And secondly, this conversation and presentation is being recorded. So I just wanted everyone to know that the recording has started as of now. So Dan, maybe you can introduce yourself and we can get started.
Yeah, so good afternoon, everybody. Thanks for coming on a Sunday afternoon to an emergency webinar with regards to the COVID-19 pandemic. First of all, as Damon's already said, I wanted to mention that the session is being recorded for future review. And my hope was to initially just orient you briefly, and then I'm going to pass you off to the team at Input Health, who's created this population health tool really within the last 72 hours. And the purpose of its creation is to enable us to respond as a collective team to really help our communities. What we're hopeful is that this population health tool will make our jobs easier and then help our communities manage the pandemic. So I want to be clear, it's a population health tool. It's been created and is intended to be delivered for the right reasons. We don't have any conflict of interest. There's no hidden cost. These are just people, including myself, a family physician, and a team of family doctors, as well as coders who really put this technology together to help us address this major pandemic that we're facing. So I'd like to thank everyone who's come together on such short notice to assist us in the work, including but not limited to the London Middlesex Ontario Health Team leadership, public health, the Ontario Health West leadership, all healthcare providers who I can see many of you on the call, including family physicians and nurse practitioners, as well as the OMA, the OCFP, the CPSO, the CMPA, Ontario MD, AFTO, and our CHC partners. Nationally, I'd also like to thank the CMA and CFPC for their support. Specifically, I'd like to thank the guys who built the solution, so the team at Input Health, specifically Puneet Seth, Damon Ramsey, and Marc Factor. What I'll do is I will pass us off to the Input team to review and demo the technology. And then after the demonstration, there's time for question and answers. And then we can also discuss potential onboarding and what the plan would look like to deploy and then scale this technology in light of the pandemic. So with that, I will pass it off to you guys and mute myself.
Perfect. Thank you so much, Dan. Really appreciate the introduction there. And thanks for putting this together. It is an honor to be presenting to all of you guys today. Let's just do a quick round of introductions in terms of our panelists. I'll start off with myself. I'm Damon Ramsey. I am a family physician based out of Vancouver. I work at the University of British Columbia, both in their student health service and also occupational and preventive health unit. I'm the co-founder and CEO of Input Health, the technology company that we're going to be discussing and hopefully volunteering to you guys today. Puneet, I'll pass it to you for your introduction.
Perfect, thanks. So to echo Damon's comments, very excited to be here and thank you everyone for attending. My name is Puneet Seth. I'm President and Chief Medical Officer of Input Health. I'm a practicing family physician here in Toronto, Ontario. I also work in occupational health at the University Health Network, and I teach at the Department of Family Medicine at McMaster University as an adjunct assistant clinical professor. Very excited to be here today.
Perfect, perfect. And Marc, did you want to do a quick introduction? Are you there?
For sure. Thanks, everyone. Marc Factor, Vice President at Input Health. I have a long background in virtual care, patient engagement, and very passionate about working with the team at Input Health and everyone that's come together to be able to manage the pandemic and flatten the curve.
Perfect, perfect, awesome. So we are going to dive in here just to give a little bit of structure on this presentation. There's only a few slides, 8 slides, which is a record for me in terms of the least number of slides as possible. We really want to actually dive into the technology and engage in dialogue with you folks about how this technology can be potentially used to flatten the curve. I do need to give a little bit of context in terms of our team, our company, and where we're coming from. So Input Health was founded over a decade ago. We're proud to say that we're Canadian run. We have offices in Toronto, Winnipeg, and Vancouver, a team size of over 40 people. Our flagship product is the collaborative health record. We are not going to be focusing so much on the collaborative health record from the perspective of how it can replace electronic medical records. We are really focusing on using technology that's built into the platform from the perspective of population health management, specifically in the time of this pandemic. Our company is independent, so we're very fortunate to be one of the few technology companies out there that was built bootstrapped, and so we don't really have actually any ties to any venture capital or any other elements out in the environment that might be making decisions for us. So we get to make our own decisions. We're a Canadian company, and I'm happy to say that we're a very ethical company from the perspective of the way that we handle patient data, privacy, security. First and foremost, as a physician-run company, our duty is to protect our patients, and that's built into the DNA of our team. I don't want to bore you guys with these preliminary slides too much. I just want to give you a sense. We're used to scaling, and we're used to scaling quickly. We've worked with large organizations like the University of British Columbia for over 4 years, managing their entire health records infrastructure for both faculty, staff, and students. We work across the globe. Amazing organizations that we count as our clients include Home Care Medical, based in New Zealand, the Mayo Clinic, of course, a well-known brand. We've been working with them for over 4 years. We're quite familiar with enterprise deployments, and we're also familiar with the sensitivity of the type of work that we do in environments that have lots of liability. Platform scalability. So we're going to be showing you this technology, but I think it's important to emphasize this technology is built to scale. We're built on Google Cloud. Infrastructure is strong, and we're able to handle a lot of hits to the system. It's just a matter of scaling our cloud resources. So that's one of the huge advantages of being built on the cloud. We're currently hosting, just in our Canadian database, 1.5 million patient records. So the technology, this is not its first rodeo. It's been around for quite some time, and it's familiar with the needs of high volume usage. That includes thousands of healthcare providers that use the platform on a daily basis to manage their entire patient populations. I want to get these things out of the way so we can dive into the tech. We are secure. We're ready for Canadian data. We're also ready for American, New Zealand, and Australian data, but we're going to be focusing on Canada today. We follow privacy by design principles. Our system is heavily scrutinized through third-party risk and security assessments on a routine basis. So key point to get across is I think we can actually move quickly here, primarily because we've done a lot of the groundwork improving scale, but also doing it safely, securely, and with privacy in mind. So what we're going to be showing in terms of the tech really can be categorized into 4 different elements. One is on the triage and surveillance side. We're going to be showing sort of an air traffic control style system, which allows patients to be triaged to the right clinical pathway and have automated surveillance technology so that we can remove the need for these phone calls, which are the current plans, which might not be able to scale depending on how large the pandemic becomes in our populations. There's the element of referral management. So we have a powerful and customizable referral management system. This is a great way for us to be able to filter priorities and statuses so that we can allocate healthcare resources effectively based on prioritization. We have a full system for clinic virtualization. This would allow clinics to move to a virtual model, so it can actually be an end-to-end solution, but this could also just be used from a public health perspective so that we can engage securely with patients using phone, video, secure messaging, and other technologies. And lastly, there is an analytics engine built into the software. The analytics engine allows us to build live visualizations and reporting on all the data that's being collected. We can aggregate this data nationally. It could be internationally. We do it securely. It's fast, and it's live, and it's real time. And we're going to be showing that to you as well. Okay, so before we dive in, I also just want to make it clear. My company, our team, and the COVID-19 technology task force that's been created, we're not looking at this as a business opportunity. We're not modeling it out. We're not interested right now in talking about pricing or costing. I know that sounds kind of unrealistic coming from a private company, but I can reassure you that is not our intention. Our intention is to be part of the solution here, to flatten the curve, and to work on preventing a lot of unnecessary suffering, protecting frontline healthcare workers, and of course, the citizens of Canada and beyond. One of the major advantages of working with us is that we are a mature company, ISO certified, for example. We have the quality controls and systems in place, but we have the efficiency, the culture, and the velocity that comes with being a startup. And we have many clients that could attest to that as well. Puneet, Dan, Mark, is there anything that I've missed before we actually dive into the technology itself?
No, I think you've hit the major points, Damon, from my perspective.
Puneet, anything to add on your side?
No, I think that things have been summarized well, and we're very excited to actually get to showcasing the technology at this point.
Perfect, perfect. So I have posted this quotation from Dr. Michael Ryan, speed trumps perfection, be fast, have no regrets. I think that's the reason why we're talking on Sunday. That's why we've got all these folks together. It's because maybe there's going to be some things in the demonstration that look like they're not ideal. We can solve those things. We can move fast. Our intention right now is how do we create a more centralized, integrated way that we handle the increasing volume of patients that are going to be coming through in terms of COVID-19 screening. That is the primary objective here. So I'm going to share my larger screen now. And we're going to start diving into the technology itself. And Mark, Dan, Puneet, I'll trust that if there's any questions that are coming up, that you guys can convey them to me because I'm not able to see the chat screen at the same time.
100%. And for all members of the audience, if you do want to use the Q&A section, I'll be moderating for you.
Okay, guys. So I am logging into a demonstration environment here. This is a cloud-based platform. The only requirement that's needed is Google Chrome and a decent internet connection. Everything goes through an encrypted channel. So all the data that's passed between the server and the end user is encrypted using SSL. I am logging into Input Health. For a lot of you guys, this is the first time you're seeing the platform. There's a lot of functionality here that we're not going to be focusing on because our interest is specifically showing the population health management tool and how we can actually potentially streamline a pathway so that we can manage patient flow. Before I dive into actually going through some example patient flows, I want to illustrate a few components of our system that you guys can imagine have a lot of flexibility and scalability. First of all, we have a questionnaire or Questionnaire builder. This allows us to produce any type of branching logic-based questionnaire, and we have a way to distribute these questionnaires directly to patients using smartphones, through text messaging, through email. Basically, as long as they have internet access, they would be able to complete questionnaires. So this is an example questionnaire that's been built, which is the COVID-19 screening questionnaire. And you can see it's a relatively friendly interface. It's showing you in sort of a mock iPad environment right now, but the patient is able to answer questions. And these questions can go into different directions based on branching logic. The nice thing about the system is that it does support multiple languages as well. And also, the branching logic can go as deep as you want it to go. So any conversation that theoretically we are able to have live person to person, we can translate into this tool. So what I was showing you there was a preview of a questionnaire that we just built for this demonstration. I want to show you how easy it is to actually build a questionnaire. So I can go in here and add a new question and say, for example, do you feel safe? And that would add that question into this specific screening questionnaire. So the nice thing about the system is we can imagine that as this screening and surveillance program grows, we would probably be building a few different collections of these screening tools, which would be available and distributable to the population that's registered into the system. I'll pause there for a second. I can see some question activity. Is there any reason to stop right now, Mark or Puneet? Just want to make sure.
Nope, I'm managing it.
Awesome, fantastic. So that's one element. You have a fully functional questionnaire engine. What's nice about the system, especially for anyone here who's data focused, public health epidemiologists on the call, we have a custom data system which allows you to on the fly produce the data dictionary from which those answers will populate. So what I'm trying to explain there is when you build a data point and a person answers a question and it's linked appropriately, this can feed that data point specifically. And by doing this, we're organically building our registry of patients. And this data is actually coming directly from the patient itself if it's a questionnaire sent to their phone. But theoretically, that data could be filled in by healthcare professionals, family doctors, nurses, and other folks that are involved in the delivery of healthcare. So we have a powerful questionnaire engine. Couple that with custom fields, and you have a way to really rapidly collect discrete and organized data. Lastly, there is a full workflow management system. So I'm going to be connecting these all together through a presentation of a live patient interaction in here. But just so you can see the elements involved, this workflow dashboard allows us to create pathways. And in this case, you can see, for example, initial triage, person under investigation, hospitalized. It's presented in a format that we've adopted from principles of Kanban project management. Some of you guys might be familiar with Trello. It's kind of a similar concept, but instead of managing a project where you would have tickets inside the columns, we actually have people. And when we have people, what we can do is actually move them across the different settings here that are defined by the columns, which are phases. And that allows us to actually track the activity live. What's also incredibly important to note is we're tracking time and we're tracking all these interactions so we can identify early on where there's a problem potentially in the supply chain, where there's a clog or some sort of inefficiency that's resulting in not ideal delivery of the healthcare service. Puneet, Mark, do you guys have anything to add before I actually go through a patient flow here?
The one point I'll add here that is probably visible there as well is the fact that we also measure the amount of time people spend on these individual stages. So looking at things from a population and community perspective, if there's quality assurance or the need to be able to understand the metrics around time to different stages of care, that can be measured as well.
Excellent. So the elements, just to be clear, we have the questionnaire engine, we have the custom fields, and then we have that workflow manager. And then the last thing I should mention is there is a record. There's a record for the patient. And you can see that here. Just one second here, confirmed. I think there's a duplicate patient record. Okay. So Mark has, nicely contributed his data here. We can see he's 36 years old. There's a full record here of all the interactions that we could be having with this patient. So without further ado, I'm actually going to flip into more of a demonstration from the patient perspective to show you guys how this actually all connects. So a patient could theoretically be driven to a simple page, which is the entry point into the system. In this case, we're looking at sort of like an online booking modality, but there's a few different ways that we can do this, including referrals, where they could actually be coming from the community, from nursing homes, et cetera. But in this first case, we're gonna actually be going through this as online booking. So have you used our service before? If the person says no, they're gonna actually be asked to register as a new participant in the system. So I'm choosing an appointment time that I'm requesting, and I'm going to create a new person here called Bob Jones, sample data, of course, and I'll add some, use Puneet's email here. So what's happening here is Bob is actually at the first entry point into the system. He's requesting a triage virtual visit. And he's acknowledging that he's requesting his appointment. It still needs to actually be confirmed. Once he submits this request, the system is queued and set up so that he completes a questionnaire prior to that initial contact, that virtual visit. This is me as Bob. And I should mention, he can be using his tablet, he can be using his desktop computer, he could be doing this on his smartphone. It's very, very simple and lightweight, so it supports most of the tech that people access the internet with. So Bob is going to go ahead and fill out this questionnaire. He's filling it out for himself. He does have a fever. He's got chills, no shortness of breath, no chest pain. He's got cough. No fatigue, no runny nose, no sore throat, no digestive or GI symptoms. And then it's going to ask us some questions that we're basing off of the recent guidelines, whether he's been in close contact with a person who's confirmed. It's going to say yes. And that was an airplane contact. Have you traveled outside of Canada or been in close contact with a sick person who has traveled outside of Canada in the last 14 days? Yeah, I was the traveler, or Bob was the traveler. He was in South Korea. That list, by the way, can be updated. So I know there's new countries we should be adding. And then we're actually going to ask some questions that are more related to demographics and screening risk from the perspective of, is this person living in a multi-generational household? Are they living in student housing, or, what's the sort of modality there? So he's a one-person household, lives in a condo. As you can see here, we would identify whether people are staying in retirement communities or nursing homes, etc. But he lives in a condo. And asking him if he's a healthcare worker. So that's another important data point for us, because obviously we might want to treat him a little bit differently if we know that he's going to be accessing or in front of patients himself. And I'll say I'm a lawyer. Should I be screened for COVID-19? So what's happened here, just to recap, is Bob basically registered into the system. He booked an appointment for virtual triage, which is actually going off of a live scheduling. So there's a appointment scheduling system, and the times that are shown to him are based on the shifts of the people that would actually be able to interact with Bob. And what he can see here is that he's completed his pre-visit questionnaire that was assigned to him. And what we can do is flip for a second back to Input Health from the provider side. And we can see that very elegantly in Dr. Ramsey's inbox over here, Bob's questionnaire has been inserted. So I can see his answers really quickly, and this would be very nice because once I actually see Bob as a patient, I will have this information in front of me and we can actually risk stratify him even before he's come in. If there was something that he said that was particularly high risk, there is an alerting system built into the questionnaire engine where it can send a message either through text or email to the appropriate person so they can reach out more in a quicker fashion. So Bob has filled out this questionnaire, and just to be clear, when he does that, he's actually providing information that is going to be feeding into a database. So this information, it's not going into some static PDF form where then we need to get data analysts to remove it and put it into a database. Rather, it immediately is providing me the opportunity to actually confirm that his data looks good and actually apply it to his profile. So the reason why this is important is that what we're what we're trying to do is increase the efficiency of our healthcare system in the context of what sounds like a surge of volume. We can't have people manually entering patient data points themselves, especially in the context of a world where probably 60 to 70% of people would rather easily be able to insert their own data into the system. Puneet, Mark, I just want to make sure that I'm not missing anything, or if you guys want to add anything, please jump in at any time.
Good for now.
Perfect. So what's happened now is Bob basically self-registered into the platform, and he did request an appointment. And I'm going to go ahead and actually confirm his appointment after I looked at his questionnaire. So he's been confirmed. We can actually send him an automated notification. That's going to go to Puneet's email address over here. And this can have a bunch of information about what's going to happen. All of our notifications in Input Health are completely customizable. So you guys can actually change these according to the different needs. And as I mentioned, we can also support multiple languages to help facilitate our multilingual and multicultural society. So,
something to also note here is that if it is booked for a virtual visit, a video camera and or a phone icon will show on the schedule, and all instructions for that virtual visit will be sent out to the patient as well.
Absolutely. Which is an important point because as we start virtualizing a lot of clinic functions, we're going to notice that there's a lot of stress on the front desk staff and also on patients in terms of making sure that they're tech ready for that kind of interaction. So Bob, he actually booked an appointment for March 16th. And what I've moved to is our population health workflow manager. As I alluded to, this is a customizable system. So all these columns or phases that you see here, these are based off of like an initial translation of the guidelines. But we can actually move and modify this and adapt it to the pathways in the local community. And you can now also have multiple workflow boards based on different pathways. So for example, if we're tracking patients that have high psychosocial risk, let's say for example, the homeless population, we might want to have a workflow board that's very specific for them because they might have different needs in terms of these interactions, and they might be at higher risk, just as an example. So when Bob schedules that appointment, he comes into this queue, and I need to insert him into the pathway. I do that by essentially starting his visit, and you'll see here that he moves to the bottom of the queue, and we've started the timer. So now he's actually part of this tracking system. Now, I'm going to show you guys from the patient perspective how this works. So give me a second while I reflect my screen. So what I'm doing right now is actually blasting my iPhone onto the screen. This is always a little bit tricky. The reason why I'm doing that is I want you guys to see the patient perspective as well. Can you guys confirm that you can see my iPhone?
Confirmed.
Perfect. Thank you, Mark. So you'll see here, we basically on the left side are looking at, we're looking at the provider view. So the provider could be working remotely from home. They could be at a public health authority. You know, they are decoupled. They're in a separate location from the client, who in this case, I've logged in as Jeremy, which is on the right side. So that phone part on the right side is representing the patient who's using an app in this case to communicate. And on the left side, we are looking at the provider view. And so Jeremy here, he's actually already been inserted into initial triage. And so I now have him in the pathway where I can move him between these different phases so we can track how he's doing. If I open up his record by clicking here, it takes me into a channel from which I can communicate directly with Jeremy. So let's try this out. I'm sending a message. You'll notice on the phone side, it comes in and pops up. as a push notification. So Jeremy could be, you know, on Instagram or sort of outside of the app. But what's nice about this is that it comes in as a push notification, and that gives us a live channel of communication directly with the patient. Why is this relevant? Well, we're creating a population health tool here. We've created one. And one of the things that's hugely advantageous is if you have direct communication with the people that you're tracking, so that we can have efficient communication, whether that's through video, whether that's through chat, whether that's through an asynchronous message, like a secure message like email. That is all available. And once they're in the pathway, we're tracking all of their interactions as well. So I'm going to step back for 2 seconds here and talk to you about these columns again. The columns represent these pathways. And basically, we're making the assumption that lots of triage staff people or nurse navigators or physician's assistants or doctors themselves, they will be on this system. And what we don't want is deviation from protocol. So protocol can actually be defined in the logic that allows you to define what moves a person from one stage to another. So for Jeremy, he's in initial triage, and I could have a video visit with him right now. I'm not going to do that, but I could click the video button here and it would actually call his phone and we can have a back and forth. And I can document that encounter using some sort of template. I don't think we've had too much time to build those templates, but here's an example. I could actually fill in this information here and save it, and that goes into his record. But what's really important is after I'm done with Jeremy, I want to actually make an action. So when I click on initial triage, it gives me the available transitions. So I can move Jeremy to person under investigation. I can move him to low risk or asymptomatic monitoring. And these are just different columns, just like you see here. And the rules are defined by the way we define the protocol. So I can't make him jump into any phase because there might be steps that are needed prior for that to happen. So based on his answers, which he gave me that are putting him at higher risk, I'm actually going to move him to person under investigation. When I do this, we can see now on this board or the air traffic control, very elegantly, Jeremy has been moved onto the bottom here under the PUI column. So his time spent there is being tracked. And part of the whole reasoning for this system is, aside from enforcing protocol, it allows us to see if people are falling off and we're losing touch with them, which would be a major problem. I'll pause here for a second. Marc, Puneet, anything that you guys want to add before I continue to move forward?
Yeah, so I'll just bring up a point regarding, I understand that a number of questions have come up with respect to the questionnaires and how that information might flow through these stages as well.
Yes.
I know some questions have come up regarding user interface for the questionnaires in terms of text size or being able to convert from text to speech. So any comment about that?
Yeah, those are great. So what's nice is once we, the reason why I showed that questionnaire builder in the beginning is that's a component, that's part of our arsenal. That's a weapon that we have to use, hopefully against COVID-19. And what that means is at any moment, I have the ability to either schedule automated questionnaires for patients or theoretically on demand, send them a questionnaire so I can get a structured data collection unit from the patient at any given time. And part of the reason why this is really, really important is we want to limit live interactions that are not collecting discrete data as much as possible, given the impending resource burden that's going to happen on the system. So questionnaires, as I mentioned, can be sent through text message or email, or they can be pushed directly to an app on the patient phone. Multiple different methodologies in terms of getting it out to them. And they don't need to have a high-speed internet connection. All they need is some basic internet and some sort of basic browser. It could be Internet Explorer, Chrome, whatever. So for the most part, we have pretty good coverage across the country in that case. You can also assign a proxy person who's representing, let's say, a person with disability or an elderly person who maybe doesn't have access to the right tech. Did I miss anything there, Puneet?
I know, that's perfect.
Excellent. So what's really incredibly nice is the last thing we want is a population health tool where it's dependent on us having to use phone conversations with patients and then having people transcribe their answers. And that's the real nice thing about this is I have a direct connection with Jeremy, and he can theoretically chat with me or I can chat with him, and this can happen over time as we move through the pathway. Right now, he's a person under investigation, so that's his current state. And we can see that there are 3 people. There are analytics behind this. So if we're starting to see that there's 10,000 people under the PUI category, we might want to figure out how to accelerate or where things are getting lost or what's surging and where. So this is the underlying reason for the way that we've designed this system. Now, once Jeremy is person under investigation, I probably will want to submit a requisition form theoretically to get him tested. So this is building out a form. It's going to pre-populate with his data, and that would allow us to actually send that requisition off. And theoretically, without having to see him in person, we could get him tested and wait for his result. I'm going to assume that that happened, and he actually came in as positive. And because his symptoms, which we discussed on his virtual visit, were not too bad, we're now going to actually move him to home quarantine. You'll notice the other option there was, hospitalized. So obviously, if he was having severe symptoms, we would be pushing him into go to the hospital, and then we would move him into the hospitalized column, which allows us to track how many of our patients are actually in hospital and how many of them are being quarantined at home. My understanding is, and I know this is all moving targets, but my understanding is basically there is a lot of dependence on notions of people getting phone calls every day when they're in quarantine or in isolation. I think that that is an unfortunate reality in 2020, where phone conversation, while it might be necessary for certain populations, lots of people could probably be monitored in a more automated fashion, which is what we're going to be showing here. So I moved Jeremy into home quarantine, and what the system did immediately, and some of you guys might have picked up on the right side, is it assigned a patient task. So something that Jeremy has been asked to do. I'll show you what that looks like. So right now he's got 2 assigned tasks. They can come in as push notifications. One of them is to watch self-isolation video. The other one is to watch a hand washing video. So tasks are generic action items. They allow us to push to the patient that we're tracking, and it allows us to actually validate whether they did what was asked of them. So he's going to watch that hand washing video. I'm not going to bore you guys with that. And you'll notice that it's completed. So on our side here, we can see he's watched the hand washing video, but he hasn't watched the self-isolation video. Now, a task could also be to fill out a questionnaire. It could be to fill out a form. It could be to read an article. It could be to phone someone in the public health authority and notify them. There's many, many different types of tasks. I'm showing you guys the basic concept here, which is that we have a way to push things to patients so that they can actually do them hopefully by themselves and allow us to work efficiently as we manage a population at risk. You'll also notice on the top here, above assigned patient tasks are staff tasks. So the person who's the air traffic controller here, who's managing this board, we don't want them to have to remember all the protocols, especially because they might change. So when I moved Jeremy into home quarantine, it automatically has cued me to schedule a daily questionnaire that goes to him. So what I will do here is I will say every day, I want at 8 a.m. for Jeremy to fill in an active daily monitoring questionnaire. So while he's on quarantine, we're able to get him to fill out a tool which updates us on his symptom progression and allows us to track whether he's getting worse, potentially whether we need to get him in a hospitalized mode, or whether he's just status quo doing well at home. But the nice thing about this is that we don't need to manually phone him every day because he's able to check in with us through this automated tool.
We also have the ability to attach multiple questionnaires to this schedule. So you can do a GAD-7, a PHQ-9, for example, to follow his mental health throughout time as well.
Absolutely, that's a great point. And I will also mention there's an alerting system. So if Jeremy stops answering the questionnaire, it can actually push an alert to a coordinator so that we can find out what's going on. Is it a technical problem, or is he getting much worse? What's going on, so that we're losing that data stream. I will also mention that we recognize that not everyone is going to be able to do these kinds of tasks, which is why the system can be developed to push to a proxy person like a family member who's completing it for, let's say, a person with disabilities or an older adult who has a lower technological literacy level. So I'm going to go ahead and save that. And so I've done the appropriate tasks. We can see that Jeremy never did he never watched the self-isolation video. I can sort of cue him on that. Hey, Jeremy, make sure to complete that self-isolation video. It has some good tips. So that's me pushing, a chat directly to him. And this is hopefully getting the point across, which is we have a very elegant way to track patient flow across this pathway, and also assign tasks on our side and also on the patient side, so that we can convert protocols from their current PDF format into a live engagement system.
Mm-hmm. And I also just want to notice when Damon is on the chat and he's messaging a patient, the system actually realizes the most recent and most frequent chats that are being done. So with automation in mind and efficiency in mind, as a clinician, you have an ability to automate those chats that go out to the patient. So if there's standard things that you want to say to a patient upon greeting them into the chat room at every given time, that could be done with the click of the mouse by Damon clicking on the bar down below.
Absolutely.
Yeah. I'll add one more point here that I think is a relevant question that was brought up, which was how do people know when they should move from home quarantine to hospital, for example? So what type of notifications do they receive to let them know about transitions in care? Damon, could you speak a little bit to that?
Yeah, absolutely. So right now, this is a very rough example that's been created in the last 24 hours. What we have the ability to do, and because the protocols are also a moving target right now, I just want to show you guys from the back end. So this is the administrative settings. You need to have the right permissions to be able to do this. But you can see here are the current phases that are in the system. And what we can do is we can actually define the way that those transitions occur. So initial triage allows you to go into these different categories. These are the limitations. You can't jump from initial triage to, let's say, exit testing, which would be a phase that's indicating that we're doing follow-up testing to assure that you've resolved your infection. So the logic is built in through this tool on the backside. And then we can actually queue the person. So when I move someone to asymptomatic monitoring, there can be a confirmation message that explains what that means. So by moving this person here, you are indicating they are low risk, but we will continue to monitor their symptoms through a scheduled questionnaire. And then before the person actually moves the person between those tickets, it would actually come up and get them to confirm that that's actually what they want. but the reality is that, you know, it's going to be defined by the pathways in the local health authority, or local region, I should say. Okay. Dan, I also want you to be able to jump in here as well with any questions. I'm getting close to the 1 hour mark, and we also want to have time for a lot of back and forth on questions. So does anyone feel like I've missed anything big? It's quite possible because I've not slept for the last 48 hours.
I think you've hit most of the major components, Damon. And is there a way that we could control this more centrally or regionally? So if OH West wanted to set a standard for all of public health and all of primary care, could they define that? I know you're going to show the heat map, but is that a possibility to define rules by regions or provincially?
100%. So as I mentioned, part of the reason why we're coming at this with a lot of passion is that we recognize that our solution is quite scalable from the perspective of those configurations where you can have multiple pathways. They can be regionalized, and they can sort of adjust for the local requirements. So yes, in short, it's very, very flexible for those scenarios. Now,
I'll also point out one more thing, which is a given, but wanted to make sure it was explicit. The platform, of course, is PHIPAA compliant in terms of regulatory compliance here in Ontario.
Absolutely. So I've brought in a special guest, Nate, who's one of the directors at Input Health and also is an analytics expert on our team. He's also come in as a panelist. Nate, we're going to go through some of these analytics dashboards together. Can you hear me?
I sure can. Can you hear me?
Yep, absolutely. So you guide me and I'll show what you've put together in record time.
Okay, so before we actually get to the positive test tracking, let's actually go through screening mass sending. So what we can do is we can mass send questionnaires to the whole patient load, and then we can analyze the answers to those questionnaires. So if you hit the filter drop-down list here, so what I'm filtering is anybody who doesn't have the COVID-19 screening questionnaire completed to date. I could also find all patients who've gone to this clinic in the last year. We can modify all those different filters. So this is finding in the demo, there are 6 different patients. Now, this isn't our QA. We are pushing this pretty quickly, so I'm not sure if this actions will work, but let's try it. So in here, we actually can load all 6 patients. Perfect. So you can hit the schedule questionnaire. We can send that questionnaire over the next hour.
So that would be today, right? 15, whoops. Sorry.
There you go.
So we're going to mass send this out at like 7 p.m. today, right?
Yeah. So we could send that to 10,000 people. It might take 30 minutes, but it doesn't matter because we schedule it. So we would actually be sending the screening questionnaire. So, but it doesn't matter in this example. So hit start. And it would go through and it would send all the different questionnaires. I didn't check all these different patients. Normally I would filter out any patients that don't have certain notification settings. So I didn't tweak the demo in that way. So you could just close this screen.
You got it?
But yes, we actually can mass send questionnaires to all the different patients under any filter. Now, when those questionnaires come back, I'm actually counting a 1 if they've traveled to any of those countries or traveled in the last 14 days, if they've been in contact with the COVID patient, or if they have any of the 3 symptoms. So the questionnaire I'm using is a bit different than yours. So if you go to the mass sending high risk follow-up, so this is the dashboard that I created, finding all the questionnaires that are responded to, and the patients are high risk. So you can see that travel risks, symptom risks, and contact risks. So then we're recommending that these patients get screening. So we also can send different questionnaires depending on different risks. I don't have the mass actions in here, but we can find a list of patients who completed the questionnaires who are at risk, and then we can mass send a follow-up questionnaire on what their next steps should be. And we can tailor that on a per site basis, because those steps could be different depending on where they are. In certain cities, you would go to this hospital or you would call 811. So we can tailor those questionnaires to follow up. Any questions on that? Okay, the next dashboard that I think is looking fantastic, it's very basic, but it's the positive test tracking. So we can either do this in a couple different ways. I'm actually looking for any active lab results in the system. We can also use patient data points where somebody just flags a patient's chart as being positive. So over time, we went from 2 to 3 additional positive from March 10th to March 12th. It also can use heat maps, and we can zoom in and out of those heat maps. We also report by age, by gender and sex, and then there's a report at the bottom of this dashboard that you can just jump to the patient's chart. So if you want to jump to Jennifer Smith, you can hit that patient link and go directly to her chart. You also can sort by age, so you can concentrate on patients over a certain age group because they're at a higher risk. So this can all be tailored on a per site basis. Because we're cloud-based, all of our data is in one location, so we can actually filter by certain domains, which the client would only see their domain, but we could also do it in mass for the whole province of Ontario.
Yeah, so this is fantastic, Nate. I really appreciate you putting this together literally in the last 2 hours before the presentation. I think the real take-home message on the analytics that we're showing you guys is that very rapidly we can sort of complete the circle here. We have the patient doing a lot of the data entry. We have validations through the healthcare providers or the organizations that are tracking them on this dashboard. And all of that data feeds into an industrial grade data center, which allows us to do live reporting. So really, this is end to end. And I think that that's going to be a major advantage. Right now, I see in the environment lots of single tools that are being produced. I see lots of websites being produced where it's a screening questionnaire, and then basically the process ends there. That's not impressive to us. I think what we need is to really have this end-to-end integrated population health tool so that we can really, in a efficient fashion, track patients and then identify what's going on and where, and how can we actually reduce the pandemic risk through different actions. And that's the main point of this presentation. I think if I haven't missed any big functional pieces, guys, shall we shift to answering questions directly now?
Yeah, I think that makes sense. There's one question that I think is relevant, which is less to do with functionality, but more about the practical application and things such as training. So the question was around what is the training time to get a physician up to speed? And what are the maximum number of patients that a doctor could be able to see or follow with this workflow? So I think that's a great question. And I think a lot of this comes down to the nuance of how we actually end up moving forward. And at a high level, in spirit of the way this is going, we want to be able to have a collaborative relationship with the public health units and the regional health teams, so that we would rely on local training to be able to happen. From our end, we've demonstrated that we were able to produce easy to use interfaces and web-based training that can be able to be scaled. But we also know that a lot of this will come down to making sure that this is well supported at the front lines.
Perfect. Were there any other questions, guys? I wasn't able to actually follow the chat stream over there.
We've been managing the majority of the questions as they come through.
Perfect, perfect. So maybe what I'll do is, as they're coming through there, I want to set some context here. As I mentioned early on, we are willing to work fast for the right groups that are interested in flattening the curve with us. What that means is Input Health's entire team has been shifted into COVID-19 mode. We have an incredible staff that's across the country, representation in Vancouver, Winnipeg, and Toronto. In this virtual model, this doesn't really matter where we're physically located, but we are ready to move fast so that these tools could actually be readily released. I will mention that health IT projects are notorious for being slow, for being very risk averse, for being over budget, et cetera, et cetera. Some of the advantages of working with a company like ours is we're pulled in when we need to move fast, when we need to solve problems, and when we need to create scalable solutions that are customizable to moving targets, in this case, protocols. In this case, we have no idea what 2 weeks is going to look like. And what we need is a system that can actually adjust accordingly. I didn't get a chance. I will just really like risk it, and I'll go ahead and try to do a video call with Mark. So I'll click that button here. Sometimes that interferes with the webinar software, but you can see here, I am actually calling Mark. And I hung it up because unfortunately the sound echoes during the webinar. So there is a full video function built in here too, for anyone who's curious. But that's, I think, a little bit more of a side point compared to the tracking functionality, which is what we're emphasizing through this workflow dashboard.
I'd also like to note that while we were on that chat and or video function, Damon, you do have multiple clinicians have the ability to chat with that individual patient. All of their avatars will show, and there will be a record and transcript of that, as well as you have an ability for multiple clinicians to converse with that patient via audio and or video. So while in the video, if you want to make it audio only, you can. As a clinician, you can take that video, put a picture on picture, go to a disparate solution to do some of the work that you need to do, and come back with the video always remaining on your screen. So there's a lot of different options in terms of how you can communicate individually and as a team.
I did notice a very pertinent question from Paul Woods, which I'm sure you guys answered. But the question for everyone to hear is, would you be able to, over time, use AI to estimate probability that a particular patient has the disease on clinical and epidemiological criteria? Absolutely yes. I don't want to overpromise. We need to actually train the algorithm, and we need to have the logic behind that. But we've done a lot of work with our data science side, where we're able to actually start doing some predicted analytics. As long as the data is in there and we have the model, sky's the limit, and that would be an excellent addition because, again, we have to assume that there's going to be decreased healthcare resources and increased volume on our system. And that's particularly where automation and machine learning is going to have a big positive effect. So I really appreciate that question.
Guys, can I chime in just for 2 seconds to ask 2 questions?
Yes.
So one question is the question around primary care or HIS integration of the tool, which I believe it's not integrated, but correct me if I'm wrong. And then the second question was for doing video, is it webcam based, or could people do it with their mobile phone or any kind of camera that they have?
Puneet, I'll let you answer that first part.
Could you repeat that first part again, Dan? Sorry.
Yeah, so the first question was about integration across platforms like the current primary care EMRs that exist in the HIS like Cerner and Epic. My understanding is that this sits outside and on top, but we would all use input as a way to keep track of that at-risk population of people who have a URI and have recently traveled and probably within the next 48 hours haven't traveled, given the spread of the pandemic.
Absolutely. So the plan with this would be for this to be a pandemic response platform. So it would sit above and beyond the existing health information system that's in place.
Right. And then I think one other comment that Paul Gale brought up that I think is quite appropriate is in terms of who would manage the dashboard at a high level. This is really intended to be having all the providers or patients and caregivers pushing in that data, and then public health at a higher level, or whatever pandemic table is formed, could actually manage the population from a very high level. Is that kind of correct in terms of the way things are set up and arranged?
Yes, absolutely. That's exactly the way that this is configured. It also relates to the question from Francine. How scalable upwards to several provinces, the whole country is this? The stack in which we're built is designed to scale. When we built our technology platform, it was under the premise that we wanted to have a central health record, collaborative health record platform that could actually allow facilities to operate across the entire country on single accounts. So because of that groundwork that we did prior to this pandemic, we're using that infrastructure to allow for that kind of level of scalability, which is why we're kind of doing this call to action here, where we have this software, it's ready relatively. Of course, the protocols and the actual setup and configuration, we need to get agreement. We need to have the right authorities there making those decisions, but we are ready to go. And I will jump back to that slide. This is not the time to be sitting and trying to come up with the perfect solution. Right now, this is the time for what do we actually have available for us? How fast can we prototype it? How fast can we test and QA it? And how fast can we launch it across the country? And what I'm saying is our team is available to do this. And we're doing this because it's the right thing to do.
And with that being said, as your second question, Dr. Lemire, in terms of the business model, we're avoiding the need for any business model to be associated with this at this point in time. Our goal is to do the right thing, flatten the curve, work together, mobilize troops, resources across our organization and across all organizations within Canada that are dealing with the pandemic.
Yeah, I mean, I understand there's like a natural skepticism towards private business and companies and in healthcare, and that's very, very legitimate. I can tell you, as the majority, shareholder owner of this company, our interest here is primarily to flatten the curve. This is not a bait and switch. This is not some sort of opportunistic business opportunity. You have me recorded on the screencast saying that. First and foremost, I'm a doctor. Secondly, I'm a Canadian citizen. And thirdly, I'm a business owner, and I'm really touching on the first two right now. Excellent. So that's exactly 1 hour. This conversation has been recorded. So we will actually distribute the video, the screen share pretty shortly. We will also be announcing our COVID-19 technology task force. Hopefully tomorrow there's going to be a release about that. We've put together an amazing team, physicians, lawyers, public health, infectious disease. These are experts that are willing to volunteer their time to provide guidance on the decision-making related to technology solutions approaching this pandemic. And I'm very happy for anyone to reach out with any questions to me directly through Twitter. We'll be sending out some contact information and dealing with things accordingly. Assuming Dan, Mark, Puneet, Nathan, if you guys don't have anything else to add, I think we'll stop here.
Thank you for the time, everyone. This was a wonderful opportunity, and we're looking forward to engaging further.
Yeah, thank you all for the demonstration. Damien, if you don't mind, I just want to make one comment as it relates to the London Middlesex Ontario Health Team.
Yes.
So we're going to take this presentation, engage with our stakeholders, and then if there is a decision to move forward that's made by the OHT leadership, then we'll ensure that all messaging and coordination, to your point about ensuring that protocols are all in alignment, are aligned. We're going to work as fast and as hard as we can, and we'll stay in touch with everyone tonight to make sure that we're all on the same page. But I wanted to thank everybody again for being on a webinar. 100 people on a Sunday afternoon is great. Thank you so much.
Appreciate everything. Appreciate everyone's comments and questions, and hope to hear from you soon. Best wishes, and I hope everyone has a good Sunday evening.
Thank you, Dan, for coordinating this. Thank you, everyone.